always say we did the best we can is the motto of the mediocre. My first grant was with pregnant and addicted women, and at the same time I gave birth to my daughter, my second child, and it was during the era of crack cocaine.
Jan Pringle, Ph.D., is the co-chair of the Pennsylvania Department of Drug and Alcohol Programs Clinical Standards Committee and the founder and director of Peru, the Program Evaluation and Research Unit at Pitt. Dr. Pringle has conducted numerous health services research studies and program evaluation efforts involving but not limited to innovative addiction treatment, intervention and prevention models, medication adherence, enhancement interventions and patient access to care, and screening, brief intervention, and referral to treatment, SBIRT. Dr. Pringle developed a framework for assessing organizational health and guiding systems transformation, which has been used within the Veterans Health Administration primary care practices, as well as other healthcare sites and entities.
I see the system, the drug and alcohol system, acts a lot like its patients. And that's because it's been treated a lot like the patients. It's been treated as not really on par with other areas of healthcare. It's not been given the resources. It's not been given the ability to have its authority over what it does or lead what it does. And so you see similar behaviors between the system and the patients, which is common. And so what we're doing is we're working with the system to help it develop so that it ultimately can take control of itself and move every patient, every single patient, to optimal health, wellness, recovery, and choice. And that's our vision now for the organization I've developed at Pitt. Well, I happened upon the field. I was recruited to be the director of research for a large drug and alcohol treatment facility in Pittsburgh. And I had training in psychiatry, not necessarily in substance use disorder treatment. And before they would allow me to do anything, they had me sitting in on groups and participating in groups and actually meeting with the counselors. And what really struck me about the field was the spiritual aspect of it. I have a family history of substance use disorder on my mother's side, her father. And as a child, she would talk about it to me. So to me, it started to make sense that what they were doing was trying to help heal people that my mother had encountered as a child. But the spiritual component and the fact that it was a holistic illness, mind, body, spirit, really spoke to me. And I don't exactly know what happened at that point, but I was pretty much sunk at that point that this was what I wanted to do. And so I really put a lot of energy into building this program for this treatment facility. And my first grant was with pregnant and addicted women. And at the same time, I gave birth to my daughter, my second child. And it was during the era of crack cocaine. So I really got involved both as a new mother, but she was a very colicky baby. And in fact, her pediatrician said she acts like a crack baby. And I felt that it was probably higher power giving me the opportunity to understand what these women are experiencing, who don't have the resources and supports that I had. And so it was actually the neonatologist who treated them who told me what to do to fix her colic, which is the same thing she did with the babies who had been exposed to crack cocaine in utero. So from there, I just got involved, and the field initially sniffed around me, didn't know if I was going to be a good fit because I came across as a bit of an egghead, but then saw that I was starting to get very caught up and engaged with the programming that was going on, and very engaged with the patients, that they call them patients and clients, they go back and forth, that the field eventually, at least at that facility and in other places, started to embrace me as somebody who they felt safe with. I cannot say that I fully understand their life experience, but I began to understand it better and better. So I think I have a better sense of understanding recovery and the process than many folks who do the kind of work I do, having worked with all kinds of patients, sitting down talking and understanding their life experience and being involved in developing ways in which they can have better treatment experiences. And that just made me even more enamored with the field. Because I have a saying that folks who achieve recovery, in my opinion, in a chutes and ladders sort of way, they shoot up the ladder because they understand the price of their soul, because they had to buy it back. The rest of us, I think, only understand its approximate worth. And so, to me, I've always had enormous regard for people as they go through the journey of recovery. And those I know who have worked their programs for a long period of time and have never deviated from that, I can see that they actually are much better people than I am in many respects. They're always looking at their true north, their compass, their truthfulness, their ways of navigating the world. And that's just an enormously, heartwarming, and I feel very humbled and really grateful for having been involved in this field. Well, initially, I was interested in doing specific programs and trying to find grant funds to not only implement these programs, but also evaluate them. So the very first program I did, which was for pregnant and addicted women, new to the field, brought a developmental pediatrician, neonatologist, and we also were linked to a program that provided treatment. We came up with a strategy of outreach to the pregnant woman that involved a visiting public health nurse, what they called indigenous outreach, which are recovery support individuals now, and then also a child development specialist who came in and helped to potentiate the bond between the mother and the baby. And from that, the women actually wanted to be involved in treatment. We did not believe that any woman should be discharged, that we used that outreach model to keep them engaged. We didn't realize we were ahead of our time, because that's what they do now. We got in huge trouble with the field at that point. We were enabling, we were blah, 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 blah. And it didn't seem seemed stupid to me, because these women were largely addicted to crack, cocaine, and their bottom was death. It wasn't the same as for the literature that was written in the 70s, which was for white men who were alcoholic, who their bottom was that they're going to lose their job and their wife might leave them. To me, it just seemed wrong for them to think that they had to go out there and reconsider. And there were a lot of women who said that what we did saved their life because it caused them to believe they could be decent mothers and good mothers, and that there was a path to that. And though their path to recovery, as we see it in terms of total abstinence, it was a path that had its fits and starts, but we embraced that. So our program, the field, the treatment system was like, get her out of there. So essentially, we had to sort of back out, and they used what we did to develop, we hear, Healthy Start in Pennsylvania, some of what we had done. And so I learned about the belief process that the field has that you really have to understand. So I sort of approached things differently, and then we did other kinds of programs and evaluations, and I even did research. And went from I think I had a secretary to begin with, to a staff of maybe 10 staff at this treatment facility. It started to go bankrupt. And as I could see the writing on the wall, I went one midnight with a U-Haul and got all of my materials out of the place, delivered it to another facility which was owned by the health system, so I wasn't stealing it per se, and then negotiated my departure to Pitt, which I was able to do. And then from there, helped build a think tank, a 501c3 think tank that still exists to be able to address issues in addiction, and then began to develop actually some work outside of the field to help me understand how to change the system, which is the field, from an organizational perspective. And now I'm addressing overdoses through community coalitions, and we've actually demonstrated we can reduce overdoses through the coalition work. We're looking at the integration of medication-assisted treatment in rural areas with wraparound services and a process to actually collect data that shows what's going on with the patient between those systems. So it's sort of a health information exchange. We're also looking at ways to screen patients in all sorts of settings by all kinds of healthcare professionals. It's called ESPERT. We're one of the first to have done that, and we now have trained 6,500 healthcare professionals and more every day. Looking at integrated care models, so you take mental health, substance use disorder treatment, and primary care and integrate them in a way that the patient doesn't get lost in the process. And we're helping Pennsylvania with that as well. And as a consequence, I've gone from just a small number of staff. Right now I have close to 60 staff, and we have about 20 active grants. A lot of the process of what I do now is implementation and looking at ways to help systems and programs learn how to change. I see the system, the drug and alcohol system, acts a lot like its patients. And that's because it's been treated a lot like the patients. It's been treated as not really on par with other areas of healthcare. It's not been given the resources. It's not been given the ability to have its authority over what it does or lead what it does. And so you see similar behaviors between the system and the patients, which is common. And so what we're doing is we're working with the system to help it develop so that it ultimately can take control of itself and move every patient, every single patient, to optimal health, wellness, recovery, and choice. And that's our vision now for the organization I've developed at Pitt. It was the belief system. The belief was that you had to hit bottom, which was probably true if you were a white, middle-class man who was primarily addicted to alcohol, who had the social supports around you. Maybe you needed to be scared a little bit about things that were part of your intact psychosocial system, but we weren't dealing with that. And it took the system and the field. I think it's taken, there's still issues like this. I'm still dealing with this on some of the integrated care models. This fear of enabling, which it is a fine line, but I don't believe that you ever completely throw someone out in the cold. You may decide that certain kinds of treatment aren't working, but you still keep them engaged in a system in some respect. And that just, to me, makes common sense. But I think most of the field feels that way now, and especially for women, because it's, what's the outcome going to be if you don't? And the issue of this being intergenerational is just going to continue. And it's just a very difficult disease because, it actually doesn't cost as much as diabetes and cardiovascular disease to treat. It's actually, the patients are more compliant than they are with diabetes and cardiovascular disease, and the outcomes are better. But someone who's diabetic doesn't hit you over the head for a candy bar, and isn't your mom and dad who wasn't there for you when you were growing up. And so therefore, it creates a lot of, I think, issues. And it really tests us as a society as to what extent do we believe we're responsible for everybody in our society, as well as to what extent do our walking away from people, not making them feel they're valued or connected, and that there isn't a support for them in many respects, create what becomes addiction. And I think we have to still, here in the United States, grapple with that. I don't know in my lifetime if we'll get to the end of the road, but I think we need to think about it. It's the perfect disease to demonstrate in your culture the degree to which you believe you are your brother's keeper, and the degree to which you think what you do to the least of my brethren you do unto me. And mental health problems are similar, but substance use disorder still has that taint to it that folks still have to work to understanding and seeing the human that exists, which was what was so great for me, to go into the jails, to go into the places that typically someone who has my educational background and even my upbringing would not go, and sit down and talk to individuals who are struggling with addiction, to find a part inside of them that is no better or worse than parts inside of me, and to connect with them, and to realize that in that connection, there is something in you that has to rise to the occasion. Not something in them, but something in you. And that, to me, is what is the beauty of working in this field.
Tell me about working in prisons.
I had a couple of programs I was involved in. One was a program where it was an alternative sentencing program, and it was for women. So I would go in and interview women in the county jail. It was not prison, it was county jail, and understand what their circumstances were and help them determine who was appropriate for the program, and then I helped evaluate the program. And I was involved also in evaluating another program that was involved, again, with the county jail, that was providing treatment in the jail and then continuing treatment outside of the jail. And what I really was really interesting to me, because I'd go into the jail and I'd go up on the floor where I was to interview a woman, and the women all run to the front because they can see who's coming up on their floor. And the first time they all yelled out, "I have that dress." And I thought, wow, where did I get this dress, and how did they get this same dress? And that was kind of a little bit, made me think, Then the next time I go, they yell, "I have that outfit." And then I realized this was just a way they greeted, at least me. I don't know how they did it with others. And then I thought, gosh, what they're trying to say is I've got something in common with you. And then that just blew me away a bit. And then whenever you sat down with the women, and they'd lock me in a room with the women, and hear what their stories were, and I realized a lot of these women had undiagnosed psychiatric disorders. And though they had eventually developed substance use disorder earlier or later, or whatever, it was pretty clear that they had, many of them had mood dysphoria. They had mood lability. It was bipolar or some issue related to that, and they never got any help. And because society didn't really think that it was ladylike for some of these women to act the way they did, they had the book thrown at them. And there was really, in some cases, it was a slippery slope for them. There was not really going to be a lot of help to get them where they needed to go next. And that was pretty daunting for me to see. One woman, she was Hispanic in Pittsburgh, when our population at that point didn't have many Hispanics. She got into a fight with a guy that I guess she said was, that he was being, I don't know, he was being inappropriate, whatever, and she hit him. And she got arrested and she got thrown in jail and he wasn't thrown in jail. And so, of course, the stories you have to sometimes realize they're not all true, but I saw a lot of disparity there, and especially with the women. And then when I talked to the men were often, their lives had been ones in which they had made some left-hand turns when they were 13, 14 years old. And the world does not like men who have made those kinds of decisions. And they essentially, they just start down the slippery slope as well. And then their social network is different, and they have a hard time once they get, especially a felony charge, they can't climb out of the hole. And sometimes that hole is created when they're 17 or 18 years of age. And that was, most of the time, I challenged myself to be able to find a way to relate with each of these folks so that they would feel that I was respectful and that I was listening to what they had to say. And that at the end they felt that the interchange was a positive one and it was a positive interaction. And I would really challenge myself to really try to find that part of them that was that, I call it that, that element that's no different amongst us. And that part, that work stuck to me to this very day. And I teach students and my staff, I say, you talk from your heart, and you connect with your heart. And it's cute to see my staff telling other staff, you talk with your heart, you connect with your heart. And here we are talking in big, important meetings, and they're doing this, and that's what I learned through that whole process. It was very, very eye-opening. I enjoyed it. I like working in the criminal justice system when I have. To create a vision that they're going to make sure no patient client is left behind, and that they'll do whatever it takes in an open-minded way, using practice-based evidence that you collect in the process of learning how you can get and approach individuals better, patient feedback, immediate feedback, and to become a way to sort of to learn how to speak and sell and market what they do legitimately based on legitimate outcomes, as opposed to getting buffeted around where they're the last in line to be able to receive payment for their services at a level that's below what really is the total cost to provide that service. They would know their costs, they would know how to negotiate it, and they would also be highly effective at what they did. And they would not settle and they would not rest until they were able to do that for every single person that came through their door. And if that were the case, I think we could make big changes. It's not really always incumbent on those that have not treated the system appropriately, just like it's not always incumbent for those who work through recovery to say, well, my mother didn't treat me right, my father beat me, whatever. It's incumbent upon a person who takes responsibility for their recovery to also understand that they have to place whatever that is in its proper perspective and have to work through it and above it. And the system and field has to do the same.